All right. Thanks, Mike. All set. Okay, we're going to spend some time talking about some literature updates to acute coronary syndrome. And as it turns out, 2017, 2018 hasn't been replete with treatment updates. There's not a lot that's, I think, relevant to emergency medicine in terms of treatment updates. So we're going to really focus on diagnostic updates, and I've got 4 cases, and hopefully we'll get through at least 3 of them. So here's case number 1. All these are real cases, by the way, and probably represent the type of cases that you see in your emergency department as well. So first of all, 40-year-old guy comes in after a 10-minute episode of chest tightness. He's got some mild nausea, lightheadedness, no vomiting, diaphoresis, shortness of breath, radiation of pain. He's got a bunch of cardiac risk factors, examined vitals are normal, EKG, non-specific junk, so you can't ship him out of your emergency department, and troponin negative ×2. How many of you have seen a patient like this multiple times in your final hour of your last shift, right? This is the kind of patient we get all the time. And so what do you do with this patient? What's the next step in the workup that we've all been taught? Well, if you do the heart score, how many of you are heart score fans? How many of you use a heart score? Okay, great. So heart score has really become very, very common in emergency medicine. If you were to calculate the heart score, it's 3. I've written the case such that this is a patient I selected who had a heart score of about 3. And so these are low-risk patients that typically we're doing shared decision making with and sending out. And our traditional teaching has been that we're supposed to send them for a stress test. This is a flow chart from 2010, which represents what some people would consider the current, well, I hate to say this, guidelines or standard of care in terms of what we're supposed to be doing. And I'll blow this up for you. And what you see is that the recommendations are that they either get a myocardial perfusion imaging test or a stress test, some type of provocative test, which if it's negative, then you get to send them out. And the guidelines will say that it's supposed to be done at some point within the next 72 hours. If they're low risk, then you can send them out and get it done in the next 72 hours. If they're not quite low risk, then you're supposed to do it now before they go home. And I think that's the way all of us have been trained. If it's a low risk person, you're supposed to do the stress test either now or within 72 hours. And the question that I would have for you is, what's the purpose of doing the stress test? I mean, simple question, why are we supposed to do a stress test? Well, I think the reason that we're supposed to do a stress test is, in these low-risk people, is because we want to find if there's some type of underlying cardiac disease, and CCTA is coronary CTA, that's accepted as an alternative to stress testing. But what we're looking for is some type of coronary disease with the presumption of, if we find coronary disease, we're going to probably send them for a PCI or even a bypass surgery. And the idea is that if they get this aggressive workup, identify the coronary disease, and get the stent or the bypass, whatever, it'll decrease the risk of major adverse coronary events in the near future. So that's the whole idea behind doing the provocative test, where it's going to decrease the rate of adverse events in the near future, all right? So that's really what the guidelines are. Is standard of care the same thing as guidelines? In other words, in order to meet the standard of care, do you have to follow the guidelines? Well, that's really not the way guidelines were ever intended, but that's the way oftentimes they are interpreted. And if we go back to ACS, in order to follow the standard of care for ACS, do you need to follow the guideline which says that you need to send them for a stress test? Turning that around, is there enough evidence to say that you don't need to follow the guidelines? Are you comfortable saying, these are all the papers which I used which say why I don't need to follow the national guidelines? And up until very recent years, I would say you'd probably have an empty hand, but now we're gradually coming up with more and more articles that say that no, you don't need to stress test these low-risk patients. And here's 2 of the most recent ones published in 2017. I'll just take you through them real quickly. This first one looked at 1,000 patients that presented to the ED with chest pain that was not obviously ischemic. In other words, I do a history, physical, look at the EKG, and my impression, my gestalt, is that this is not ACS, all right? And what they did was they said, let's take your impression and let's also compare that to doing the stress test or coronary CTA and see what the difference is between clinical impression, low risk, versus getting a stress test on these patients routinely, which is what the general standard of care is. And what they did was they looked at major adverse cardiac events, which represents death, MI, unstable angina, which is kind of a weak adverse event, and also urgent revascularization. Well, what they found was that, first of all, the length of stay obviously is longer when they get stress test, cost is higher, PCI at 28 days, a little bit more, but not significantly different. CABG at 28 days, obviously you're going to have a few more CABGs if you're stress testing people, but no significant difference. ED returns at 28 days, no significant difference. This is what we're interested in. Our presumption is that if you do routine stress testing, that's going to pick up those patients with underlying cardiac disease, and you'll find that fewer people in this column have adverse events at 28 days, and it turned out to be no significant difference between your clinical gestalt versus routinely testing everybody with stress. All right. Second article looked at over 900,000 patients in a large database. Once again, comparing my clinical gestalt is I don't think this patient is high risk for ACS versus patients that just routinely got stress testing. And they looked at routine stress testing at 48 hours and also at a month after their arrival. And let's find out whether the patients that got the stress test have a lower rate of 1-year adverse event. You'd figure that if we're doing stress tests, the whole idea behind doing stress tests is it's going to decrease subsequent MIs because you're going to do something with positive stress tests. Well, what did they find? For the patients that got stress tested at 48 hours, there was no difference in terms of 1-year rate of MIs. In fact, maybe just a little bit more. And for the patients that had stress tests 30 days later, again, no significant difference in terms of the rate of 1-year MIs. In other words, bottom line here is that routine stress testing of patients that you thought were low risk to start with, routinely doing the stress test was associated with increased length of stay, increased cost, increase in subsequent invasive procedures, but no reduction in subsequent MIs or any other major adverse cardiac events. All right, so all we're doing is running up the bill without any increase in benefit with these patients that have a gestalt of low risk. And the patient we started with, the patients that we're talking about are patients that have a heart score of 0 to 3. What we have traditionally thought, these patients need to get the stress test. All right, now think about this for a second. Those of you that are heart score fans, when you have a heart score of 0 to 3, your risk of adverse event is about 1 to 1.7%. If you do 2 troponins, it's under 1%. All right, we've got literature saying that if the risk of a positive stress test, if the risk of adverse event is under 2%, the literature says that you're more likely to get a false positive stress test than a true positive stress test. In other words, if your risk is under 2%, doing a stress test is simply running up the bill with no increase in benefit. So what we're starting to find is that probably the way to go is that when you have a heart score of 0 to 3, or the really low-risk patients, those patients shouldn't get any further testing. Because if you do that, all you're going to do is increase the rate of PCIs and CABGs without improving the rate of MIs long-term. All right? It's actually the heart score patients that are intermediate or high, the 4 to 6s and the 7s and above. Those are the patients that probably need the more aggressive workup. All right? So, just some thoughts about that. This is where the literature is taking us, all right? Our literature is taking us away from stress testing. There's another article that just got published with identical results, maybe in the past couple of weeks or so. And we're seeing more and more literature supporting this concept that routine stress testing should not be indicated. I'm not saying that's what the standard of care is. Standard of care is determined by a jury and what you can convince a jury of, but I think there's really increasing literature to talk to your cardiologist about whether we really need to be doing these stress tests on low-risk patients. All right, I like collecting signs. People send me signs from all over the place. So this is from Boston a few years ago when they had that god-awful winter. So I'll show you some more shortly. All right, case number 2. This is a 38-year-old woman who comes in with shortness of breath, severe malaise since waking. She woke up about 8 hours ago. She was in her office and just was feeling really wiped out, so her coworkers convinced her to go get checked out. She had some mild lightheadedness, no specific precipitant. She says, "Doc, I don't really know why I feel really tired, but this morning I woke up and I'm just really wiped out. Normally I've got a lot of energy." She's got a couple of cardiac risk factors. She smokes cigarettes, diabetes, and hyperlipidemia. All right, vitals are normal. Her exam is normal. She just looks kind of tired. Again, how many of you have seen this patient before? Right, all the time, right? These are called, I think it's ironic, these are called low-risk chest pain, and yet these are the patients that we get sued for, right? I think these are high risk. Right. Anyways, what ends up happening? What's the workup? She gets the CBC, the Chem 50, right? Or the Chem 100 if you've got it. I talked about this case up in Canada, and I got these quizzical looks. And so I told people, there's really no such thing as a Chem 50. And they said, oh, okay, all right. So what is a Chem 50 in the US? No, we're just making that up. All right, D-dimer, pregnancy test, UA, chest x-ray, everything's normal. She gets an EKG. Here's the EKG. It's a little wavy. It wasn't repeated, but we'll just call it non-specific junk. It's certainly not a STEMI. It's not a clear-cut, non-ST elevation ACS. So I think she actually got a troponin sent also is unremarkable. She ends up being discharged home. Again, real case. 2 days later, she collapsed in front of her family in the kitchen, had a cardiac arrest. Autopsy showed 100% LAD. Obviously a bad outcome if we're talking about an autopsy, okay? So here is Johnny, all right? So lawsuit is filed, all right? Actually, Johnny Cochran was a defense attorney, so it probably wasn't him. But lawsuit's filed, and this ended up resulting in an upper six-figure settlement, and it wasn't felt to be defensible. So they settled the case. My role in the case was actually to see how low we can get the settlement. So it was kind of disheartening to find out that you're asked to look at a case for the defense, and the defense attorney says, I know we're going to lose this case. Our hope is just that you can argue in such a way that we lower the amount, right? But these cases for years and years would head off in this direction. The contention from the plaintiff side was that this was a high-risk group and atypical presentation. Who would have thought that a 38-year-old woman represents a high-risk group for ACS? That's certainly not what I learned. When I was in medical school, I was taught you have to be a 65-year-old woman or a 55-year-old man. And then in residency, we were taught to lower it by 10 years. And now I don't even know what the lower age limit is. There is no lower age limit. But I wanted to spend a few minutes talking about a really, really important and hot topic. This has been a hot topic for at least 1 or 2 decades, but there's been a lot of literature that's come out very recently about ACS in women. While it's true that men are at greater risk for ACS, women are at far higher risk of misdiagnosis. And what I would say is that of probably about 80 med-mal cases that I've looked over the past 12 to 15 years, 2/3 of the ACS cases, 2/3 without exaggeration, are women who are relatively young, women in their 30s and 40s, right? By far are the most common malpractice case that I end up seeing. Women are at far higher risk of misdiagnosis. Now this is a classic presentation that we've all been taught to think of, an elderly woman clutching her chest. The reality is that most ACS in women is not the elderly woman clutching her chest, but relatively younger women, oftentimes with atypical locations of the pain that you wouldn't think is ACS in the first place. And article after article after article has been published. These are just some recent articles going back to 2014. They actually go back a couple of decades talking about atypical presentations in women, 2016, 2017, a half dozen articles, and the most recent article just published several months ago, and they all have some very common themes that they talk about that are important for all of us in emergency medicine to know about. Number one, coronary disease is still the #1 killer in women in first world countries. And there's a lot of societal talk and lay media discussion about breast cancer, as it should be, but the result in surveys is that a lot of women in our society don't realize that cardiac disease is still the #1 killer. There's a very nice Canadian study which showed that a lot of women out there really don't even know what the cardiac risk factors were. They didn't know smoking was a cardiac risk factor, or that hypertension was a cardiac risk factor, and they significantly downplay the risk of having cardiac disease. Turns out women, even when diagnosed, have a higher in-hospital mortality, even when they're diagnosed and treated. People don't really have a good sense about why that's the case. And even when they are treated, study after study has shown that women tend to be less aggressively treated. They're less likely to get EKGs when they show up at doctor's offices with chest pain. They're less likely to get stress tests. Stress tests are more likely to be falsely negative. And they're less likely to get cath, and they're more likely to have delays when they do get cath. And this gender bias has been noted in every society, in every ethnic group, by every cardiology society around the world. And people are still trying to get a handle on why this is true. Women have very different presentations than men. Painless presentations are more common in women, just like in diabetes, more common in women. They more often have atypical locations of pain and atypical radiation. I was taught in residency that if somebody has pain that radiates to the right arm, it's not cardiac, which is completely wrong, completely wrong. All right? Women are more likely to have isolated arm pain, isolated neck or jaw pain, isolated upper back pain, instead of the classic crushing or chest pain. They're more likely to have flu-type of symptoms, malaise, fatigue, weakness, and studies have shown that women are more likely to be misdiagnosed as having the flu than men. You know, malaise, fatigue, weakness becomes very common, especially in older women, instead of the classic chest pressure and shortness of breath. All right? And these apply not just to older women, but in younger women as well. This is a study that we all had to read for ABEM recertification in the LLSA article by McSweeney looking at prodromal symptoms in women that were having ACS. Only 30% had chest pain. Shortness of breath, 42%. Okay, not surprising. But sleep disturbance, fatigue in 71% of women that were having an MI. Study after study has demonstrated this, and I've seen this in the med-mal literature and in cases that I've had to deal with as well. And I've said this before, maybe you've heard me say this, as I've gotten more experienced in emergency medicine, and as I've gotten more experienced in life, I've come to fear tired women. I'll just leave it at that, okay? All right, gentlemen, are you with me here? All right. So patients and physicians tend to misinterpret the symptoms. So this is another very interesting article that was published as well. Men more often have just one or two symptoms. So chest pain and diaphoresis. Oh, it's a slam dunk admit. Chest pressure radiating down the left arm, piece of cake, right? Women have more symptoms that are atypical. So shortness of breath and malaise and some nausea and vomiting and some sleep disturbance. Well, this doesn't sound cardiac. And so the studies again showed that the women patients and their physicians are more likely to misdiagnose them as having the flu because of the panoply of different symptoms that they have, all right? More likely to be misdiagnosed as non-ACS. And these 2017 articles I just came across were news to me. Women are less likely to mount significant elevations in troponins. Men mount higher biomarkers, and women's EKGs tend to show less ST elevation and more subtle or nonspecific abnormalities. Literature has shown this is true for the elderly as well. Elderly don't mount the same magnitude of ST elevation. Elderly are more likely to have non-STEMI. Women, same thing. Less likely to have STEMI because they don't mount a full millimeter of ST elevation as often and more likely to have nonspecific findings. So quick take-home points, key things to remember about ACS in women. Number one, beware ACS in women, all right? Lower your threshold for getting the EKG and for thinking about out-of-the-box presentations. They don't have chest pain as often, all right? Don't expect significant ST elevation on their EKGs. Their biomarkers may not go quite as high as younger people. They're at higher risk for misdiagnosis, so be on the lookout for those atypical presentations. And once you start heading down that pathway, be aggressive with the workup and the treatment. If they qualify for a treatment, give it. Don't maintain that gender bias, all right? All right, so quick summary of what we've talked about so far, all right? Number one, again, remember, routine provocative testing for low-risk chest pain is slowly fading. Use your accelerated diagnostic programs, your heart score or TIMI score, whatever to use it properly, discuss it with the patient, and discuss that maybe stress testing is not the best thing for these patients. Get them good follow-up and document what you're doing. And then finally, again, lower your threshold for working up women. Be aware that they are high risk, not only for poor outcome, but also for misdiagnosis because they don't present as typically. All right, so this is an unusual sign. This was sent to me by somebody in Austin, Texas, all right? I don't know if anyone here is from Austin or what kind of picnics they have in Austin. The strange thing here, they've got all these condoms and then Excedrin. And then below that is ever-ready batteries, so I don't know. Okay, case number 3. How are we doing? 10 minutes to go. All right, case number 3. This was sent by a physician in Toronto. 70-year-old man comes in with right-sided chest pain, which radiates to the left arm and lasted 30 minutes. He's got diaphoresis, so again, slam dunk. We're going to worry about this patient. It started while he was running to catch the subway. All right, so even more concerning, his exam is normal, and his 12 lead demonstrated up here shows normal sinus rhythm. It's a normal EKG. All right, rock solid, normal EKG. So what are your thoughts? I'm seeing a lot of people's heads nodding. Here's a hint. We're in a conference talking about literature updates, so something bad's going to happen. All right, let's take a look at this. So it's 11:01 a.m. So what this physician did, he said, you know what, let's get a repeat. About 14 minutes later. And so take a look at these T waves in the precordial leads, all right? So here's a pearl. I'm not going to go into detail here. It's never normal to have a T wave larger than the QRS. If you ever see a T wave that you can take the QRS and fit it inside the T wave, that is always ischemia until proven otherwise, all right? And you can take that to the bank, all right? A few minutes later, here you see STs are starting to drop, V3, V4, and a few minutes later, here's what he's got. He's got some ST depression shooting him into a big, tall, symmetric T wave. What's this called? De-Winter. This is the De-Winter pattern, all right? So after a normal 12-lead ECG, they activate the cath lab, 100% LAD occlusion, excellent outcome. And this leads me to get to, and by the way, the highly sensitive troponin, which we don't have yet in the US in most centers, negative on number 1, and then it peaked at over 50,000. The unit started at, any lab test that's over 50,000 is abnormal, right? So this is the article that I want to talk about, and I wasn't originally planning on talking about this several months ago, but it seems that everywhere I go to give an EKG lecture, people keep bringing this article up. This was published in early 2017, and it's getting a lot of press. And so I just wanted to address it real quickly. What they did in this article, they asked a simple question. If the initial triage ECG is normal, do you really need to worry about that patient? Does a physician even need to look at the subsequent EKGs, if at all? Because the common misperception is that if it's initially normal, then you're done. I mean, most of us know that you can't rely on the EKG when it's non-specific, but people have actually stepped out and said it's normal. What they did, they looked at 855 EKGs, 222 read as normal by the machine, all right? And ECGs were then overread by a cardiologist, emergency physician, and they said, well, how often was it that the ECG machine read it as normal, but we actually had to do something different with the patient? We had to worry about the patient. And what they found, that your N here is 222, because we're talking about normal. So that's your N in this study. And what they found was that only 1 out of 222 ECGs did it turn out that they had to bring the patient back immediately. The patient ended up having some ST elevation AVR, ST depression 2, and T-wave inversions in lead 3. The patient ended up getting a stress test the next day. Fortunately, the patient did okay. But only 1 out of 222 times did the ECG machine read it as normal, and the emergency physician cardiologist looked at the 12 lead and said, it's not normal. We better do something with this patient right away. So 1 out of 222, that's a pretty low rate. And their conclusion here, these are quotes, ECGs identified at triage by the computer as normal are unlikely to have clinical significance that will change triage care. And a direct quote from their article, eliminating physician review of the triage ECGs with the computer interpretation normal may be a safe way to improve patient care by decreasing physician interruptions. I mean, we all get frustrated with the constant interruptions of having to look at ECGs. Maybe we don't have to be interrupted if the ECG is read as normal. Well, when you take a closer look at the numbers, again, there are 222 normals. Here's the way I see it. Let's say you work, you see during a normal shift, you see 11 normal ECGs per shift, all right? And that means you're probably going to see 220 or reach the N after 20 shifts, all right? Let's say you've got a pretty light clinical schedule. You do 10 shifts a month. So that means every 2 months, you're going to miss one clinically significant EKG, all right? How many of you are still going to have a job if you're missing a clinically significant EKG every 2 months, right? And that's just you. I'm not even talking about your entire department, which means all of your colleagues are missing one important ECG every 2 months also. I just don't think there's any way that you can accept this article. All right, and I'm just going to show you a handful of cases here to really hammer this point home. These are all cases that have been sent to me. And I'm going to run through them really quickly. So 64-year-old, chest tightness, bilateral shoulders. Here's the initial 12 lead, read as normal. Well, this resident was concerned because there's a flip T wave in AVL, and sure enough, 30 minutes later, it turns into an inferior wall STEMI, right? First ECG normal. This is somebody who would have been in the waiting room if you follow this study, all right? And by the way, he had a VFib arrest right before going up to the cath lab. Case number 2, this is from Ontario, 79-year-old, left chest pain right into the arm and jaw. There it is, normal again. And once again, there's that flip T wave and lead AVL. This is a week ago. This is what he's got now, flip T wave and AVL. We know leads to an inferior wall later. 13 minutes later, the patient's got an inferior wall STEMI. Case number 3, 27, right? 27, it can't possibly be cardiac. This is sent from Nashville, and there's the initial 12 lead. The computer's reading this as normal early repull. You can't call it normal early repull with the flip T wave in AVL, and so she did some serial ECGs, and over the next half an hour, this turned into an overt STEMI. Case number 4, this is from our emergency department, patients in the waiting room, and has 55-year-old atypical chest pain. There's that flip T wave in AVL. The patient gets brought right back, even though it's called normal, and about 20 minutes later gets a repeat 12 lead. Let's see if you can pick up the subtle change here. All right, and the patient coded right after the EKG, but fortunately was in a room, on a monitor, got quick defibrillation, perfect outcome. This is a disaster that would have, can you imagine if this patient had been coding in the waiting room? You know, our patients would just step right over them. And so, I don't know. 62-year-old comes in malaise, lightheaded, long-standing diabetes. It's read as normal. All right, what's the abnormality here? Anyone? T wave, right, so there's hyperacute T waves in V1. What we call loss of precordial T wave balance. T1 V wave is larger than the T wave in V6. That's too large. It was called normal. There's their baseline. This was normal. Patient had an atypical story and ended up being discharged home, and the next day was found dead at home. All right, big anterior wall MI predicted. I've got about a half dozen more cases. I'm not going to spend time. I think you get the point. All right. The bottom line here is don't trust the computer. All right. You cannot trust the computer. All right. And a trivia question here. I'll tell you what. If anybody can name which Star Trek episode this was, let's see what I've got. $20. No, Todd, you're a Trekkie. No, all right. Second season. This is Time Amok. All right. So look it up. Did you really? I should have known that. Brent, I'm going to give you $20 in just a second. All right. I can't believe someone beat you, Todd, at knowing Star Trek. That's impressive. All right. Okay, so computers are particularly bad at early signs of ischemia, early reciprocal changes, and hyperacute T waves. We've got to be the experts at picking these up because you can't rely on your computer to pick this up. And as I've said before, who programs computers? Your EKG computer is programmed by plaintiff attorneys, all right? It's true, they want you to miss, all right? So don't trust your computer, all right? When there's concerns, get serial EKGs. All right, quick summary. How much time? 2 minutes. All right, routine provocative testing. Use your accelerated diagnostic protocols. ACS in women, beware, be afraid. And then don't believe your ECG computer, all right? So as you think about lunch, I've got one more case for you. This is a pretty quick case that we'll go through. All right. Okay. This was actually sent to me by one of my colleagues, Dr. Samar. I don't know if she's here, but there she is, Samar, one of the smartest young physicians I know. She ran the ECHO course yesterday. And she and one of the residents were taking care of a 24-year-old man with chest pain, no known risk factors for PE, thoracic dissection, or ACS. So 24 years old, low risk, patient looked uncomfortable. And that was all it took, all right? EKG normal, it's read as normal by the ECG machine. But Samar was a little bit concerned about the flattening of the T. It's not even really overtly inverted, but it was just flat. And the patient had ongoing chest pain, simply ongoing, and looked uncomfortable. And so what do you think she did? You're not going to activate the cath lab for this, right? She just got another 12 lead. And take a look. Inferior wall STEMI is developing flip T wave ST segment elevation. Patient went up, had 100% RCA, all right? 24 years old. That's what we're seeing. So that leads me to this final article, a very, very simple article. If you remember this article, you will save lives. It's that simple, right? It's an article that was published in one of the EKG journals, 334 patients, only 85% of patients in this study with STEMI were diagnosed on the first EKG. In other words, 15% of the STEMIs were diagnosed on the second or third EKG. So you can't always just rely on one single EKG. There's other articles that we've talked about at Resus in the past where 20% of the STEMIs were diagnosed on the repeat EKG. So key point here, when somebody has ongoing symptoms or you just have that gut feel that something might be going on, don't settle for that initial normal 12 lead EKG. And by the way, the current national non-STEMI guidelines actually specifically say that we're supposed to be doing serial EKGs every 15 to 30 minutes for the first hour. In other words, the current guidelines say that if somebody has ongoing chest pain and they have a non-diagnostic first EKG, you're supposed to get at least 1 or 2 more over the next hour before you settle and call it quits. All right? What I would suggest is anytime symptoms persist and you're concerned, I'm not talking about the squirrely chest pain, but anytime symptoms persist, get a repeat. Anytime their symptoms change, it's getting worse, it's getting better, it goes away, get a repeat. All right? And you will pick up more STEMIs than you can possibly imagine. All right? So let's quickly sum up what we've talked about. All right, so summary for this talk. Routine provocative testing is gradually fading. Know that literature. Make sure that if you're using accelerated diagnostic protocol, you're using it correctly. Shared decision making is golden with these patients. ACS in women. Women are very high risk for atypical presentations and also for adverse outcomes. We're still trying to figure out why. All right, lower your threshold for getting that EKG and working them up. Don't believe your EKG computer and utilize serial EKGs. And with that, I will conclude and hand things back over to Mike. Thanks a lot, everyone.